Thanks a lot. Just before, now you know who's on the panel. We would also like to know who is on the call. I noticed that we're approaching nearly 200 people. We would be interested in knowing who you are. So could you please put into the chat? And before you do that, please select from the little blue drop-down menu, everyone, and let everyone know where you're calling in from and what your role is there. And while you're doing that, and before we get started, I would just remind you that this is your opportunity to ask questions of our expert panel. So as we go along, please put questions for our expert panel in. We're also aware that you're all experts in this field and that you're on this call because you have interest and expertise in the field. So if you have observations or suggestions or comments that you want to make, please ensure that those go in the chat box as well. We'll try to get to questions that come up from the chat. Back to you, Danya.
So let's start with Anita. Anita, you're an emergency physician and an anthropologist. Can you tell us more about your work and what it can teach us in the emergency department interactions with our older patients?
Of course. Well, thank you for having me. So I've basically been working on research and quality improvement initiatives that are related to understanding older adults' experiences, communicating in the ED, and what their expectations are when they come to the ED. So first, I kind of want to share the anthropological perspective, which is maybe our patient-centered perspective. So the CMS measure is about eliciting patients' healthcare goals, and I think probably for many of us who are emergency clinicians, when we hear that word goals, what we're thinking about is critical illness and goals of care. But the CMS measure is meant to be broader than that and kind of get at what patients' goals of a hospital visit might be. When you actually try to use that word goals with patients and their caregivers, it tends to not go over well. And I found this both in my own clinical practice and in doing cognitive interviews with patients and caregivers, that they don't necessarily conceptualize their ED visit in terms of having a specific goal. So one thing I wanted to share is just that in the emergency department, asking people about expectations of what's going to happen or what their biggest worry is, that can be a little bit easier to ask as a question. And in terms of expectations, people tend to fit into a few different buckets in the ED. So some of them are just there for acute symptom control. Other people want a specific diagnosis, right? What is going on? What is causing my cough? Some people want reassurance against a specific condition. So that might be, am I having a heart attack? I want to make sure this chest pain is not that. Still others need help with care coordination, and then some are simply following instructions from a concerned relative or from someone who referred them in. So asking questions to figure out what bucket does your patient fit into can be helpful, and it generally doesn't take a lot of time. So Cameron is going to speak a bit more about some of his work in patient priorities care, but I think one of the key questions to ask is, what was your biggest worry coming into the ED today? Because it can change how you communicate with someone, even if it's not really changing your medical decision making. So just to give you an example, if someone comes in with a chief complaint of belly pain, my goal as an emergency clinician is to get to a diagnosis and then help them control their symptoms. And we all know, for at least in the United States, for older adults who come in with belly pain, they're pretty much going to get labs and a CT scan, right? So if what they're actually worried about, though, is that their belly pain is from colon cancer, well, now I know that as an ED doctor, and I can tell them I might not be able to answer that specific question today because the CT scan that I'm going to do is not the same as a colonoscopy, right? And that's what you may actually need to answer that question. So this question about what's your biggest worry or your biggest concern, that comes directly from Cameron's work, which, as I mentioned, he'll talk about patient priorities care, which is a communication intervention he's adapted for the ED. So I'm going to send that nod in his direction and then move on to a second point. So I want to be very practical because we as emergency staff are practical people. So eliciting goals and expectations doesn't always seem helpful. I'm going to say that it's unpopular, right? But you can think about the vast array of patients that you see, like someone who sprains their ankle. Is it helpful to elicit their goal or expectation? Sometimes it isn't. So obviously I care about this topic deeply personally, and I try to bring these elements into my practice, but it becomes very challenging with the time constraints that we face. So there's a lot of kind of standard pathways like a chest pain, ACS rule out, or someone's referred to you from clinic where things become protocolized and understanding someone's goals or expectations may not actually be that actionable as a clinician. So I've been doing some QI work to figure out what patients is it actually the most helpful to do this with, because clinicians don't want this type of information about everyone. We already have so much to digest. So the feedback that we've gotten, at least from clinicians in my system in Texas, are that there's kind of three situations where it's helpful to get this information. One of them, obviously, which I think I alluded to earlier, is if someone is having critical illness and you need to make decisions about resuscitation, intubation, intensive care, right? That's kind of fairly straightforward to us. Another situation where understanding the expectations is helpful is when there's equipoise in disposition. So if you think it's reasonable to treat someone as an inpatient or as an outpatient if they have follow-up, oftentimes, older adults want to stay independent. If given the choice, they will want to be treated in the outpatient setting. And so understanding what we would refer to as goals or priorities can be really helpful in making those admission decisions together. And then I think for non-protocolized chief complaints, which people love to hate, like weakness and dizziness, which I think are probably for many of us, we actually like those complaints because they're challenging. But for those sorts of complaints where no specific protocol may exist, understanding the patient's expectations of the visit can be helpful. So just as an example, I'm thinking about a few patients I've had in the last few weeks. So a 92-year-old comes in with several weeks of cough. His vitals are normal, right? He doesn't have COPD, his exam is benign, and the chest X-ray doesn't show anything. So understanding his expectation can help me target my care and communication. So say he just tells me, I want to make sure it's something that's not serious. Okay, he's in that reassurance bucket. Say he says, I can't stop coughing and I need to be able to sleep before I help take care of my grandkids tomorrow. Well, then we're thinking more about symptom control and maximizing his function. And then, something else that I've heard, I'm worried that my wife might catch this because she's on chemo right now and I want to be careful. Okay, so then our communication is more about infection control and that sort of counseling. I wanted to make one last point before I stop talking. So I think the last piece that I wanted to say is that knowing someone's goals or expectations might not actually be actionable unless you have other contextual information. And for us as emergency clinicians, that tends to be information about their caregiving context and maybe their baseline cognitive and functional status. And so the CMS measure, as we went over, it does have multiple components. And these components are close to, but not 100% in line with kind of what we as emergency care teams care about. So we really care about knowing about people's potential social supports after a discharge, trying to figure out if they're at their cognitive or functional baseline and what types of supports they might need for a care transition. And so I think it was helpful to see that many of the registrants were interested in information in the EHR tools, geriatric dashboards, which could be super helpful, although not necessarily the solution for people who don't use care frequently or don't have good access to care and probably will have less in the EHR. So that is what I was hoping to share.
So Anita, we started with you because of actually a somewhat provocative perspective that you bring, that when we talk about goals of care, in fact, they may not be something that we need to get at in the emergency department, at least some of the time. And so, but clearly you think they are important. Do you have any guidance for clinicians as to how they can make that decision as to what they can defer till later and what they need to act on in the emergency department?
So in some of the work that I've been doing, what we tried to do was just approach people with, in the United States, we have this measure or this subjective measure of acuity called the ESI. So we tried to do this with folks who are ESI 2 with normal vital signs or ESI 3. And that's where some of this came about of people were giving us feedback of, well, it's not actually helpful if their chief complaint is chest pain, or because I know I'm going to get my troponins, EKG, and then risk stratify them. So it's not helpful to, necessarily know their expectations or their goals. And then I think where it was more helpful is where there's some ambiguity, whether there's diagnostic uncertainty or whether you're thinking about discharging someone and trying to figure out the safety there. So at least in my own personal practice, because I don't have the time to do this with every single patient, I will choose those people who are a little bit more in the gray area of what's going to happen with them.
Yeah, and you gave us some nice points for how you do select those people. I guess the person who is critically ill, at some point, somebody is going to have to start talking about goals of care. But I guess the point you're making is really that when we talk about goals of care, we need to expand beyond just thinking about resuscitation or specific treatment measures. Is that right?
Correct. Yes, I would agree wholeheartedly.
Back to you, Danya.
So, Cameron, you too are an emergency physician with a research interest in what matters most. Can you tell us more about your work, which Anita alluded to more than once, and that we can learn from it, particularly how it connects with the CMS measures in the US?
Yes, absolutely. Thanks, Tanya. Thank you for that introduction. And thank you for inviting me a part of this webinar. It was great to hear Anita's work and how much our work aligns and overlaps. And I've so much respect for her work and very much in agreement. Our group has separately done a few research projects in this space. Today, I want to touch on one of them. Aaron put it in the chat if you want to peruse what I'm going to be talking about. There is a link there. And I was really encouraged during Anita's presentation. I saw Michelle put in the chat about asking some of these questions about concerns or worries and how it really changed the course and sort of potentially set a patient up for success by getting them the durable medical equipment that they needed. So I was really encouraged by that. The hope is that some of this work that I'm going to share can then sort of provide suggested questions sort of in a time-sensitive fashion that then you can hopefully implement in your clinical practice to improve the lives of those older adults. So the study that's in the chat was we did the study in about 2021, 2022. So COVID was sort of, not in the peak, but sort of maybe down a little bit. And it came out of a partnership with Dr. Mary Tonetti here at Yale, who's a prominent geriatrician. And Anita mentioned patient priorities care. If you're not familiar with that, Mary sort of started that. And she's done a ton of work with patient priorities care. And it's been really one of the first frameworks to really help older adults identify their unique health priorities and then align their care with those priorities. And so with patient priorities care, it was originally developed for the outpatient care setting, where there's typically a bit more time for these types of discussions and baseline knowledge of the patient. We really wanted to tailor these sorts of conversations and framework and sort of conversation guide for that time-sensitive ED environment, where clinicians really don't know the patient or really have any prior knowledge of their really healthcare. And then Anita mentioned this as well, and this is one of the things that I wholeheartedly agree with her. When people sort of, other thing I wanted to comment on, when people do hear those terms such as what matters or shared decision making or goals of care, I think most people do think of end of life or critical illness, where I agree that we definitely need to sort of think about those life-saving measures, but also then sort of expand it as well to their larger goals, as Don mentioned at the end there. And so the focus of this work, sort of building on that, the focus of the work that I'm here to talk about was a little bit different, and it was meant for that standard older adult patient coming into the ED and really trying to align their care with what matters most to them. In brief, it came down to 2 questions on that conversation guide, and we timed it, and it was completed in about 3 to 4 minutes on average, and it really proved to sort of uncover important information about the patient. And those 2 questions were, what concerns you most when you think about your health, about being in the ED today or tonight? And then the second one was, what outcome are you most hoping for from this ED visit? And so these questions are seemingly pretty simple and brief, and they were adapted from that patient priorities care initiative in the outpatient setting, but then were vetted with ED clinicians as well, sort of earlier in the process. And the brief interviews that we had with older adults really revealed that these questions opened up many concerns and desired outcomes that were oftentimes buried under the chief complaint of chest pain or abdominal pain, as Anita mentioned, in the medical record. But they really these underlying concerns and outcomes really sort of contributed significantly to why they showed up that day and what they would be potentially worried about if and when they left the emergency department and went back to the community. And so specifically, some common concerns that were frequently brought up definitely were, you have those buckets that Anita talked about symptom cause identification, plan for resolution. But then there's a sizable population that also brought up the specific concerns about really preserving their current functional status, for example, is a common thing that we saw. And then on a related note about desired outcome, we oftentimes got that, I want to go home, I want to be discharged. But then they also brought up concepts about, maintaining independence, about functional status that were still on their mind, even in the ED visit when their chief complaint didn't totally align with that. And so these were just a few examples from our population, but I think it highlights what oftentimes is in the minds of those older adults, aside from that chief complaint. And I think that there are things that I've taken away from this research project and implemented in my clinical practice. And if you think worthwhile, maybe you and your team at your home shop can do the same. And so a few times when I'm on shift and I've asked these questions, I've gotten some, like Michelle had mentioned, I've gotten some similar responses that I was seeing that maybe came a little bit out of the blue, and it prompted me, for example, to engage social work or case management if I had those resources earlier in the ED visit when maybe I wouldn't have otherwise. And this could be for resources or home support that maybe came up in that conversation. And when I think of these encounters, I kind of think about I'm trying to be proactive in that conversation, addressing those underlying concerns and desired outcomes, rather than being reactive. I think in focusing on the chief complaint, sending the person home, and then only to have them potentially return to the ED visit when it was maybe something that we could have prevented up front is sort of my goal when I implement that clinically. I'm not saying that these questions are definitely a silver bullet, or that an ED clinician should be responsible to do a 30-minute prolonged conversation. My hope is to sort of make it short, narrow, focused, and sort of get clinicians and patients on the same page and sort of closer to sort of what's driving their care seeking that day. And then there is Danya talked a little bit up front. There's definitely there is a real and financial consideration to, I think, introducing some of that. They talked up front about in the United States, the Center for Medicare and Medicaid Services and the Age-Friendly Hospital Measure. And so just sort of building on that a little bit, starting in 2025, there's a mandatory measure. It's an attestation-based measure, meaning the hospital or the healthcare system says, yes, we did these 5 things. And those are the domains that Danya brought up front. So, first, eliciting patient healthcare goals. Second, responsible medication management. Third, frailty screening and intervention. Fourth, social vulnerability. And then fifth, age-friendly care leadership. And so from just sort of wrapping up from a practical standpoint, I think if a hospital or an emergency department sort of engages in that 4Ms framework that we're probably all familiar with and documents what matters to each older adult, as in this example, then they are sort of well positioned to satisfy that CMS attestation measure. And this one, I think, definitely sort of hits those patient healthcare goals, that first one. And so I think my takeaway from this work, I think, is, where you are in the healthcare system, it might be worth having a conversation with your hospital leadership, your emergency department leadership, maybe your chief quality office about quality measure reporting and their plan for the age-friendly measure. What initiatives are in place and what locally across different departments and settings, and sort of could this one in the emergency department tick that box off for eliciting patient goals if there's nothing else sort of in place at the current moment. So I'll stop there and happy to talk further and answer any questions. Thanks.
Yeah, so you do seem to boil it down to 2 very actionable things, 2 simple questions around concerns and outcomes. One of our participants, who I take to be one of our nursing colleagues, is wondering, like, who should be asking these questions? Is this a physician question, or can you see this being actionable by others?
Yeah, that is a great question. I mean, obviously in this research study, we had hired research assistants to sort of do that and offload that. I would say the more that drink the Kool-Aid and are willing to ask this question, the better. I mean, if it is a physician that asks it, great. If it is a nurse, great. I know from a nursing perspective, there's all different kinds of, I know our nurses are inundated with all different kinds of screens, suicidality, falls, etc. So I know there's a ton on their plate already. Um, so I mean, I'm hesitant to say yes, it definitely falls on nurses, but I think anybody on the team could and should could do that.
This might go back to the first thing that we put on that came up very commonly in your responses, is that this sense that this kind of should be everybody's responsibility, and that creating a culture where everybody is interested in what the patient is concerned about, so that it can be the physiotherapist who's doing the walk test, it can be the social worker talking about what resources are available to the person. It can be the person delivering food, or it could be the person at the registration desk that kind of slips these kinds of questions into their daily practice. I'm curious to know, as one clinician to another, Cameron, how often, what is it like for you yourself asking these kinds of questions, and what experience have you had with that?
Yeah, the time when I implement it the most is when I think the disposition is on the fence, when I'm sort of unsure if they're going to be admitted, or there are reasons they could go home, or they're sort of unsure of how they want to proceed. And then that sort of opens that door and opens the conversation for sort of, okay, are we at a safe place for a discharge, or would it be better if you come into the hospital for a day or two for reason XYZ? That's the time when I use it the most. Invariably, it's probably more than once a shift, I would say. I would say I implement it.
Yeah, I think it also can come up with frequent presentations because of chronic organ failure diseases. The congestive heart failure is the frequent lung exacerbations, where no one ever has actually asked the person what it is that they're hoping for. The outcome part of your question, like what they see, I'm not asking for an answer. I'm just interested in finding out what they're thinking about. So that's another opportunity to ask concerns and outcomes questions.
Absolutely.
Danya.
Well, James, you're also a practicing emergency physician, and your research actually focuses on patient-centered outcomes in the emergency department. In addition, you do bring an international perspective as you practice in England. Can you tell us more about your research and what it has taught you about how we in the ED can address what matters most to our older patients?
Yeah, thank you a lot for that, Donya. So healthcare, and perhaps in particular emergency medicine, is full of guidelines, protocols, and pathways, all designed to help us do the right thing as quickly as possible for unwell and injured people. But it's probably not controversial to say to this audience that that approach doesn't always work particularly well for older people living with frailty, because by definition, these people have multiple problems, and often more than one problem is contributing to the presenting situation. I'm not aware of any one-size-fits-all protocolized pathway that we can use to accommodate such complexity. They just don't work when things start getting tough. When things are complex and uncertain, the solution is to go back to the basics that we were trained on, and that's to apply ethics and use person-centeredness with our knowledge of pathophysiology and research-based evidence. But I'd be naive to say that that's as easy to do in practice as it sounds. So my work on what matters was intended to give us some starting point for communication and consultations, intended really to help us do more of what's important and perhaps do a bit less of what isn't. Most of us are drawn into our specialisms by professional and personal experiences, and I'm absolutely no different. So perhaps I could share a brief example about an older relative of mine so I can illustrate the context of this study that I'll share. So this person was going through a very difficult period of recurrent falls. She lived alone and she had to call for help each time that she fell because she couldn't get up unaided. This was normally overnight and the family never got there in time before the ambulance arrived. And what she really needed was just help to get up from the floor back to her chair or bed and ideally to be able to stop falling so that she could live happily ever after at home. But what kept happening was she'd be transferred to the hospital, she'd have a head injury workup and CT scan investigations, she'd then go through the syncope workup and all those various lying standing investigations. And then because she never quite remembered what the position was in the workup, she'd then have to go through the confusion screening and all of that delirium testing as well. She was undoubtedly grateful for the professionals' time and their attention, but none of these admissions actually yielded anything particularly useful. Her overall experience ended up being quite frustrating and not so meaningful. So the message from her story is that people living with frailty need an approach that's more comprehensive and more holistic, and more about them than perhaps our emergency care system is designed to deliver and is geared up to do. To give that, we need to understand what people value as important, so that we can consider that when we're making recommendations. Dania, you might be kind enough just to show that slide, because that's something I looked at during my first PhD study, which was back in 2020. This was a methodology in summary using interviews with older people who were living with frailty, and some qualitative analysis approaches to understand themes of what people might be seeking from us when they require acute care. So it's called What Matters, and yes, this is a summary of goals, but actually I think what we're getting at here is values as much as expressed goals. The findings, they do resonate with my own professional practice, but also my personal experiences. And since this has been published, other researchers have found similar. So I'm quite confident now in the findings. On the right-hand side of the screen, we've got functioning or maintaining levels of current independence and activity. That's probably very familiar to every one of us, and we're not all people living with frailty. I think the autonomy themes on the left are particularly interesting, and perhaps these are unique to our context of geriatric emergency care. They can be simplified down to situational security, feeling safe in place and feeling secure in the home environment, and then self-determination or feeling represented in decisions. And to me, that latter, that's representative of person-centered care having been fulfilled. So additional work by Simon Moyart and Kristen Nicol have shown that goals might not necessarily change with the severity of frailty, and that at the individual level, at least, we probably can't predict them. So we do still need to take that small amount of time to elicit the values and goals, but perhaps having an overarching framework like this gives us somewhere to start from. Thank you for that, Dania. All done with the slide. So once we come to understand the outcome goals, then we can complete our clinical assessment and then work to prioritize the problem list around the person themselves. And that gets to the core of shared decision making. The result is a stratified management plan around what matters. With this, we're able to justify our approach and our decision making as genuinely being grounded in the person's values and their interests.
So you're talking about PROMs, James, patient-reported outcome measures. How do you think those relate specifically to what matters, and how can we know what they are?
Yeah, thanks, Don. Once you have a good idea of what matters, then the next step really is to look to measure it. I think a good measure of best quality geriatric emergency medicine would be the fulfillment of person-centered care, as experienced by the patient. So one way to do this, as you say, would be a patient-reported outcome measure, or a PROM, and really all that is a questionnaire considering those goals that patients have told us are meaningful, just that it's been validated with psychometrics to ensure it's measuring something consistently. There's PROMs specific for every circumstance. There's actually over 10,000 PROMs in existence, but not many for older people living with frailty in the acute care setting. As it happens, we've got two represented today. Cameron, who spoke before, developed the PROM OTED for people being discharged or having transitions from the emergency department. And my own tool, the PROM OPAC, considers autonomy and self-determination across the whole acute care journey. So the rationale behind developing a PROM was to be able to evidence and then improve the person-centered acute frailty care. I think personally that there's potential to use this in the clinical setting to help us identify and focus on what matters to the individual. But normally we only see PROMs being used in research work or audit work. We don't have anything in the UK similar to the CMS Age-Friendly Measure, but we are aware here that our service models are certainly not geared up for people living with frailty. And at political levels, there is some appetite to monitor change using something more meaningful, but we haven't quite defined what that's going to be yet. Your new age-friendly measure, it's a service level attestation, as Cameron said. Perhaps if we were to move towards something similar over here in the UK, then we'd look to complement it with something at the person level, something person-centered, perhaps a PROM, to evidence our improvement from their perspective as well.
Thanks for those comments, James. And just to direct everybody's attention to some of the comments in the chat, which is there's really some very helpful and interesting comments, particularly I would say from our geriatric nurse clinicians who probably have more experience with this kind of thing than many of the physicians do. And we will try to get to some of those questions and comments before the end. Back to you, Danya.
Well, many of our attendees did share in the pre-survey that we looked at earlier that one of the greatest challenges they have is how to integrate the questions into their workflow. And there are some details in the chat about that as well. But I do believe that our nurse and physician leads at the level 1 geriatric ED at Mayo Clinic may have some more specific answers in the realm. Susan and Jessica, can you please tell us more about the innovations you have in place or are planning to help address what matters most for our older patients?
Thanks, Danya. So one of the challenges and themes I think we're hearing in this discussion is the time constraint, the complexity of the patient, the details surrounding the care of the older adult that often I think muddy the water, create, I would say, some barriers to trying to really coalesce the information that you're trying to gather about your geriatric patient in order to provide the best care possible, focusing on what matters most. And so in an attempt to align care with what matters most, we have created a geriatric tab within our EMR Epic to align with the 4Ms. And hopefully it's creating a space that organizes a lot of the details that we're talking about that become challenging to organize as we plan for, like Cameron mentioned, maybe the fork in the road about disposition of home or hospital. So just to give you a quick just visual so that you could see what this would look like. Essentially, these tabs exist in Epic, and we'd have a geriatric tab that we can now click on, which would then organize the patients in the department by pod. This is a by pod, so that are older. And the columns in the tab are essentially organized in a way that has mostly the titles of the 4Ms. So matters, mentation, medications, 2 columns for medications. You can see mobility. We lump diet into mobility because that's when we're thinking about it the most, is when we're assessing that. And then our facility location and clinical comments. I should mention just briefly that the tab, this was the idea of the tab came about because we realized that we were not identifying where patients were coming from when they were arriving by ambulance in the EMR. And this has been a way for us to clearly articulate the location of where our patients who are residing in a facility are going when they leave, or in a way that's, transferable amongst a multidisciplinary group, including, PT, pharmacy, social work, case management, multiple nurses and providers. So
with that, we are focused today around what matters most to the patient. And I think, if we think about how we started this discussion, I think we think a lot about goals of care, and the critical illness or the disposition fork. But I really think that what matters most is much, much broader than that. And an example of that is a patient with marked dementia that I cared for recently that is asking for the television to be on and for Pepsi to be at the bedside. And lots of, it makes me kind of smile a little bit because the providers caring for her in the facility didn't realize something was wrong until she stopped asking for those things to be there. But something as simple as, the environmental adjustments that have to be included in the care you're providing in the busy department can be what matters most that day. But from the broader view, the tab in general, I think would create a way for what we think probably are the most important details that are lost in the record, lost in the busyness of the care we're providing, lost in translation with communication barriers, into one place where we can all view them, make sure that the things are being done, and we're addressing the care needs of our older adult. So
Jesse,
with
I'm
that,
just going to pose a question here because there's quite a lot of interest in the chat in this and enthusiastic support for it. A couple of things that come to mind is who would be able to post comments in the Matters tab, and what kind of, like the Pepsi and television one is very telling, but what other kinds of things have you seen in that, or could you imagine seeing? So who has access to it? Who can post there, and what do you see?
anyone can post in it. So it could be, I would say it aligns well with what the conversation was prior to this being shared, but anybody can. So it could be the pharmacist, could be the nurse, could be a PCA, could be anybody who could post. Second question related to what other things go in it. We have an advanced care planning tab that we can hover within the Matters column that takes you to the tab, which the first tab in the hover is really another sort of organized summary of advanced care planning documents, whether it's orders for resuscitative care during recent hospitalizations. There would be advanced care planning notes, which are short notes related to specific goals of care. Not necessarily all resuscitative care. I would say it expands beyond that. And then I would say the documents that, at least in our state, that correlate with directions regarding how to care in a resuscitative event, whether that's CPR or not, a physician order for life-sustaining treatment, or an advanced care advanced directive, which is, much longer document, but still containing vital information regarding, I would say, more of the goals regarding critical illness. Susan?
Yeah, and it's fluid. So again, our older adults have longer lengths of stay. So just as the patient is progressing through their care, anybody like a pharmacist, if we need to have them reconcile, that they will hopefully kind of look at this geriatric tab to look to see if they have any home critical meds that need to be given, or are they NPO for some reason. But on the offset too, with the diet, I just saw a question in the tab that it's more to make sure that we are feeding our patients. So in a clinical comments, for example, we could say soft diet, but it's mostly to make sure that we are addressing their diet needs, and that green check is to make sure that that was done and addressed.
Susan, given that as you say, patients do stay a long time, including in the waiting room. One of our participants, Swapna Peter, is wondering, can this tab be used, activated from the time the person is in the waiting room, and how early can people get access to it?
Yeah, so hopefully, and this is a work in progress. It's under construction. Just wanted to add that this would be included and based on age. So someone could just click into geriatrics, and all the geriatric patients that have registered in the emergency department would fall under this tab.
Yeah, and certainly, we don't screen with ISAR or we do not have a risk stratifying screening tool implemented in our department for various reasons. But certainly you could consider, I would say, funneling or down on your number of patients that would fall into the tab. Right now, ours will be age only. But certainly, if you had an implemented screening tool, you could consider, adjusting your number that way.
Good. And just before we go to Aaron for some other questions, and I think there's a lot of interest in this tab, and I'd be interested if people could post in the chat if you have something similar at your own institution, and how it works at your place. And as Maya Cubbett, who I believe is from Australia, has just said, they have a similar dashboard in Epic for their care coordinator team. And Todd James is wondering about how this interacts then with the inpatient care of the patient. Would they have full access to it? Jessica?
Yeah, I don't think the inpatient team has access to our ED track board. Certainly, we've discussed some of the information needs to transfer to the inpatient side, especially from a facility perspective. If we didn't identify where they came from at the start of the ED visit, the inpatient team is having to, I would say, accomplish the same things and ensure that they have the right information. So being able to transfer it across is definitely something that we need to consider so that we're not, duplicating work and we're working together across disciplines.
And again, just before we get to Aaron with other questions from other people, is there a way for other hospitals to learn how to create a similar care information in Epic? Or did you do all of this work yourself? Do you know if Epic, which many of our hospitals are on, whether this is already built in?
I don't think it is.
Yeah. Yeah, we built this, and actually it was as we were going through our journey of accreditation, to bring a focus to geriatric care for all domains. So for social work, for everybody who looks at our track board, which they do, it was a one place to consolidate all those important things. And I'm just thinking for the inpatient setting. So a nurse giving a report can just look at this and just go through all those domains and just relay all that information just at a snapshot without digging around within our own Epic.
Yeah.
So I just direct everybody to the chat, which is kind of blowing up with a lot of really great ideas about how you can integrate it, including, I'm pleased to see one from my Toronto neighbor, which has a geriatric tab. So, but thanks very much, Jessica and Susan. Aaron, over to you. You've been watching the chat and keeping track of things.
Yeah, some great questions, and thank you for asking and participating in your solutions. One of the pieces when we were talking about what matters for our patients, it can a wide range, the full gamut. There's been some points where with intersecting with palliative care, and from the panel, what is your experience with integrating palliative care with your Geri ED, and how does that even then connect with what matters for the patient in a little bit more narrow field? Thank you.
Who'd like to take that question? So about how you can integrate or what role palliative care has in what matters most. James.
Yeah, for me, I don't necessarily draw a huge distinction between palliative medicine in the ED and geriatric medicine in the ED. What I practice, I like to think, is person-based frailty medicine, and the principles are compatible. The reason I say that is there is a difference between palliative care and end-of-life care, which I suspect is what the question is trying to get to, because palliative is more about comprehensive holistic care, which is what we do best. And that palliative approach can start at the same time as the curative approach. It may be that we're just giving 99% curative, 1% palliative, but over time, that number may change. And of course, at the time that it becomes 100% palliative, then our focus is then on end of life care.
Thank you.
Any other comments from Anita or Cameron about integrating palliative, the role, what the overlap between palliative and what matters most is?
James, I greatly appreciate that response. I know from my experience, a lot of don't fully take the full palliative, being able to work with their chronic conditions. And I know from my own experience that many times when patients have like a new diagnosis, they need palliative care, like a longer family session. Has there been anyone else's experience with in the ED consulting as an outpatient for palliative care from the ED as a consultation or referral to outpatient care? Well, I guess that would be a no. One of the experiences that I had with in my former position is that we actually would have palliative care the physician do a consult in the ED, and we found initially that it's a great idea because it really helped our ED providers. But then the issue was it wasn't very effective, and so what we did was transition to, for those patients that needed longer care, like a longer duration have a family meeting with palliative care, we transitioned that to an outpatient. So it was a nice connection point from the ED. If we identify we're not going to be able to have the time for what they need, be able to do that as an outpatient. So thank you.
Good, and there are some very interesting responses around palliative care in the chat as well. And I wish we had a chance to bring everybody off mute and let everybody talk, because there's some great ideas there. But we are coming to the top of the hour, and Danya, if we could go back into the slides, we are going to have to start wrapping up. All of our speakers have prepared just some take-home points, which we won't go through in detail, but these will be available on the webinar on demand site. So as you know, this recording is posted there, as well as the slides with all of these take-home points, as well as the chat, which contains a lot of valuable information, including a great link to EPIC's resources for age-friendly resources, as well as the question and answer period, and a list of resources. So we'd urge you to visit our webinar on demand. In fact, one of the resources you'll find is a blog that was just published this week by one of our presenters, Dr. Anita Chary, and her team, talking about strategies for eliciting healthcare goals in the ED. Next slide. Danya, I'll let you do the announcement.
So for our next JETSI webinar, we're going to be talking about frailty screening and intervention and the CMS Hospital Measure. So continuing our current series, and that would be discussing part 4. So we definitely look forward to seeing you on February 23rd at 3 p.m. Eastern. This would be the registration link on the screen. Aaron will probably pop it in the chat as well, and you can just go to the JETSI website to register as well.
We might end up having all the same speakers back since they're all experts on frailty also. But just a reminder that if your institution or you are interested in improving care of older people in the emergency department, the GEDC is likely your home, so please consider joining us. Next slide. We can't do this work. We haven't been able to do this work without the very generous support of the John A. Hartford Foundation and the West Health Institute, and we need to constantly be thankful to them for their assistance. I think that brings us to the end of these slides, but just before we finish, I do want to let you know about some upcoming changes in our webinars. In the past 6 years, since the first days of the pandemic, the GEDC has brought you a monthly or bi-monthly webinar. There have been 40 webinars on many different topics, but all addressing excellent care of older people in the emergency department. And I've really enjoyed producing and hosting all 40 of them. It's been a lot of fun. But now it's time to pass on that pleasure to someone else. So today marks the last of the GEDC webinars that I will be hosting, but certainly not the end of the educational series. I'm pleased to say that Dr. Danya Koja will be taking over from me, my co-host today, but full-time host as of February. And we have a great schedule planned for 2026. I've really enjoyed creating this series over the years. It's been so much fun working with all the many experts that we've been in touch with across the United States and around the world. I do want to say a special thanks to the GEDC team, notably Heather Wojtowicz, who has made everything work smoothly and seamlessly throughout all of these. And for those who were around at the very beginning, when we were still running this off our kitchen counters and tabletops, I do want to say a thanks to Laura Stabler, our previous GEDC coordinator, and to Connor Sullivan, who did a lot of problem solving and quality improvement over the years. And many thanks to all those international experts who have really been generous in sharing their expertise, in American and international. So that brings today to an end. I'll see you all in February again for Danya's next great webinar, but by that time I'll be in the audience. So it's been great working with you. Bye, everybody.
Don, just real quickly, on behalf of the dozens of chats that are coming in right now across, I just want to add all of our verbal thanks. If I wish we were in person, because now would be the right time to like hand you like a cool trophy or some flowers or something, but you'll have to just live with incredibly deep and heartfelt thanks. Geriatric